This time we thought we'd, thanks to Dr. Sathish, Dr. Ashwin, and Dr. Tulsi, they've put together a very interesting package for all of us today. So I'm just going to hand over to Dr. Ashwin. Take it.
Thank you, Jonathan, for the opportunity. And this is a case which we came across a few months back, and which we had to integrate with pediatrics and with the lab services, and they helped us in reaching to a diagnosis. So we thought we'll share that experience. So it will go in a sequence like we will present, Dr. Jemima from our team will present our clinical aspects, then Dr. Tulsi will take us to the lab, and Dr. Sathish will elaborate on the pediatric presentation and finer aspects. So over to Dr. Jemima. Thank you.
Good morning, everybody. I am Dr. Jemima, final year registrar from the Department of Respiratory Medicine. So here today is the case presentation on the topic no burst, no kill. And the case goes by, she is a 31-year-old lady from Andhra Pradesh presented with complaints of shortness of breath, MMRC grade 1 for the past 3 years that progressed to grade 3 in the last 3 months. Her current effort tolerance was around 200 meters. She had no orthopnea or paroxysmal nocturnal dyspnea. She also had cough with expectoration for the past 1 month, which was yellowish, copious in amount, and non-foul smelling. She had no hemoptysis. She also had previous seasonal worsening of cough and sputum production for the past 3 years. And also it was associated with intermittent wheeze with seasonal exacerbations. She had no history of joint pains, skin rashes, skin tightening, or photosensitivity, and there was also no recurrent ear or skin infections and no altered bowel habits. Past history, there was no past history of tuberculosis, but there was history of treatment for recurrent lower respiratory tract infections since childhood. Her last admission for LRTI was 3 months back. There were no other significant exposures. Family history, she was born to non-consanguineous parents and she also had siblings who were normal. There were no history of similar illness running in the family. On examination, her pulse rate was 108 per minute, her saturation was 90% in room air, and her BP was 110/60 millimeters of mercury, and her BMI was 15, which indicates that she is underweight. And general examination otherwise was unremarkable, and respiratory system examination, on auscultation, there was bilateral normal vesicular breath sounds, and added sounds, there were bilateral coarse leathery crepitations along with expiratory wheeze present in the mammary, infraaxillary, and infrascapular areas. So then we did some investigation. So initial blood investigation, her hemoglobin was 12 and total counts was 10,400. There was no peripheral eosinophilia. Her platelets were in normal range and her renal and liver function tests were also in the normal range. Since she had a cough with expectoration, we had sent the sputum for analysis. The sputum expert was negative and routine culture also did not show any growth. Echo was done which showed normal RV and LV function. Only tachycardia was noted during the study. A spirometry was performed. As we can see in this flow time graph, she has blown the spirometry for only 3 to 4 seconds. And the spirometry result showed restrictive ventilatory defect. But as I already told, she did not perform the spirometry adequately. And also ABG showed there was type 1 respiratory failure. So then we did a chest x-ray. Since she was little sick, we had done a portable x-ray. This is a chest x-ray AP view, and it's a centrally placed film. There are bilateral non-homogeneous opacities in both the lung fields. Overall, this is not a very good quality chest x-ray. So based on the clinical findings, then we proceeded with the HRCT thorax. So the CT actually shows a lot of motion artifacts here, but as we can also see, there is interstitial septal thickening we can appreciate, and also there is bilateral mild cylindrical bronchiectasis changes in this CT. So overall, based on the clinical radiological findings, the patient has bilateral bronchiectasis now, but the etiology, the cause for the bronchiectasis is not yet identified. So here in this slide, it's a small overview for how to approach a case of bronchiectasis to identify the etiology. So starting from the history, first we should ask whether the patient had childhood history of measles, pertussis, or infections with adenovirus. As we know, in India, TB is very common. So we should also ask that history because as a part of post-TB sequelae, bronchiectasis can occur. And also we should ask for history whether there is history of recurrent sinusitis or pneumonias, that is pointing towards whether there is primary impairment of mucus clearance, because in certain cases that can help us think towards primary ciliary dyskinesia or cystic fibrosis. In that cases, we can evaluate for the same. So when there is also a history of recurrent infections along with skin infection or abdominal infections, we should also think whether there is any underlying immunodeficiencies like CVID or CGD. So we should also ask history for asthma, because in severe asthma, there can be immune response to fungal antigens leading to ABPA. So ABPA can also present with central bronchiectasis. So that history also we should ask. We should not miss out asking history about connective tissue disorders, because diseases like rheumatoid arthritis, SLE, or systemic sclerosis, they can also present with bronchiectasis. And also family history, we should ask whether any siblings or anybody else in the family has similar complaints, whether any history is pointing towards cystic fibrosis or primary ciliary dyskinesia in the family. That also we should ask. So then the first investigation is HRCT thorax. That will not only help us to confirm the diagnosis of bronchiectasis, but also will help us to know whether there are any congenital anomalies like William-Campbell syndrome or Mounier-Kuhn syndrome that is present, or any sequestered pulmonary segment, or there is any intrabronchial obstruction because of any tumor or any foreign body that is leading to bronchiectasis. That also we will be able to see in the HRCT thorax. So in our patient, since we needed to evaluate for the etiology, we did a basic autoimmune workup. ANA showed 1+ and rheumatoid factor was negative. Since she had history of recurrent infections, we also did the immunodeficiency workup, and all the immunoglobulins were in normal range, and sweat chloride was was in the range of 10, which it's a normal value. But the nitro blue tetrazolium test, it showed a negative reaction. So what does this test indicate? So this test is done to assess the function of neutrophils, mainly their oxidative burst capacity. So normally during the intracellular killing of the pathogens, the neutrophils will release reactive oxygen species. So this will react with the nitro-blue tetrazolium, and it will form a blue color precipitate called formazine. Here in the right side image, we can see that the neutrophil has changed color. It is a normal reaction. So if it is a positive, it means there is a normal neutrophil function. The oxidative burst is happening normally. But if the neutrophil is not producing the reactive oxygen species normally, this oxidative burst reaction will not happen and the color change will not occur. So the negative reaction means the oxidative burst is not happening normally in the neutrophils, which indicates that there is chronic granulomatous disease. So chronic granulomatous disease is a disease of the phagocytes. So before going into detail about the disease, we will see what is the normal neutrophil function. So neutrophil is an important component of the innate immunity. It has multiple functions, starting from identifying the pathogens and doing phagocytosis, engulfing of the pathogens, or killing of extracellular pathogens by neutrophil extracellular traps, and non-oxidative killing by degranulation, releasing enzymes like myeloperoxidase, lysozymes, and lactoferrin, or by oxidative killing by release of reactive oxygen species inside the phagosomes. And also it helps in cytokine production like interleukin 1 or TNF alpha, which will it acts as a chemokine and attracts other cells at the site of inflammation and infection. So here in chronic granulomatous disease, we are mainly concerned about the NADPH oxidase system, because that it is required for the generation of reactive oxygen species. So NADPH oxidase it contains many subunits. Absence of any one of the components of the enzymes will decrease the neutrophils to produce the reactive oxygen species. So neutrophils will fail to exhibit a respiratory burst that increases the oxidative metabolism during phagocytosis. Because of this failure to generate reactive oxygen species, the neutrophils cannot clear the pathogens effectively intracellularly. So this leads to recurrent infections. So not only the intracellular killing of the pathogen is affected, the reactive oxygen species is also required for formation of the neutrophil extracellular traps, because the reactive oxygen species, it helps in the formation of histone degradation and chromatin condension that is required for the formation of NETs. So once the function of a neutrophil is done, that it has done the work of clearing the pathogen, it is effectively cleared by the activated macrophage by a process called efferocytosis. So this is also affected in CGD. So not only the clearance of pathogen is affected, the normal clearance of neutrophil by the macrophage is also affected. So normally the apoptotic neutrophil will be cleared by the macrophage and the inflammation and will subside at that point. But here, because of the deficiency of NADPH oxidase, that process is also affected. So the macrophage cannot effectively clear the neutrophil. This will result in autoinflammation. And also to contain the infection, there will be granuloma formation. So to look at the prevalence of the disease, the global prevalence ranges from 1 in 1 lakh to 2,50,000 live births. There are two forms of the disease, either autosomal recessive or X-linked form, X-linked recessive form. In areas where there is a high range of consanguineous marriage, the autosomal recessive form predominates. So in India also the prevalence is similar to other global countries, but since we have more of consanguineous marriages in India, the autosomal recessive form predominates here. So to look at the simplified pathology, that there is defective killing of the microbe by the neutrophil. So since the neutrophil cannot clear the pathogens effectively, there will be granuloma formation. So to look at the systemic manifestations of CGD, because of the recurrent infections, there will be recurrent lymphadenitis, and because of respiratory infections, there can be recurrent pneumonias, liver abscess, or gastrointestinal granuloma, or recurrent skin abscesses. So mainly coming to the respiratory system, what happens in respiratory system in CGD. So the problem is mainly because of the recurrent respiratory tract infections. The commonly implicated organism here is the catalase positive organism, because normally in CGD, because there is absence of the reactive oxygen species, our host immune system will try to use the organism's reactive oxygen species to to utilize and kill the pathogen. But the catalase positive organisms, they themselves will utilize and reduce the hydrogen peroxide. So our host immune system cannot utilize it for killing. So the commonly implicated organisms here are Staphylococcus aureus or Salmonella, Klebsiella, Pseudomonas. And the most important fungal infection is Aspergillus fumigatus. So this leads to a vicious cycle. Because of the recurrent respiratory tract infections, there is and bacterial colonization, it activates a dysregulated inflammatory response. So this can lead to airway dilatation and damage, leading to bronchiectasis. So when the airway is dilated and damaged, it cannot effectively clear the mucus. So stasis of mucus is a very bad situation, because it favors harboring of more pathogenic organisms in that, and again recurrent infection will occur, and it goes like a vicious cycle. So this is the cause for bronchiectasis in CGD. So looking at the management part in short, for chronic granulomatous disease, the definite management is hematopoietic stem cell transplantation. So whatever other things we are doing, it's for supportive management. So we should also take care of their diet and nutrition. And because of the chances of recurrent infection, antibacterial prophylaxis is given with cotrimoxazole, and antifungal prophylaxis also with itraconazole is given. And they should be advised immunization with all routine vaccines as per the immunization schedule. But BCG is avoided in these patients because of the risk of getting infection. And before doing any procedure, like any invasive procedure like sigmoidoscopy, colonoscopy, or any invasive procedure, they should go for an antibiotic prophylaxis. For the treatment of bronchiectasis, so the main problem in bronchiectasis is the stasis of secretion. So we should aid in clearing the secretions by bronchial hygiene therapy and airway clearance technique. It will not only prevent the recurrent infections, but will also help in ventilation and overall improvement in lung function. And they should also be advised routine vaccination. Even for adults, we should advise routine vaccination with yearly influenza vaccines and pneumococcal vaccine. And when the patients present with infections and exacerbation, we should manage them with appropriate antibiotics. And if there is airway involvement as per the history or spirometry showing obstructive features, then we should advise them inhalers with bronchodilators, long-acting beta-2 agonist and muscarinic antagonist. So this is the short management of bronchiectasis. So with this, the presentation is done. Thank you.
Could you just explain to our registrars what differentials they should think of? And the second point is, when do we send for this toluene test?
Hmm.
Because we may not otherwise think of it from the medicine side. Thank you.
So based on the history, currently her worsening of symptoms was for 3 months. But she had past history for 3 months. 3 years. She was having intermittent symptoms of cough, breathlessness, and wheeze. So from this, we can see there is both airway involvement and parenchymal involvement. So that can point towards whether we should also think of whether there is obstructive airway disease like asthma. We should think. But one history here is currently she is having cough with copious expectoration. And previously also she had during seasonal worsening, she had similar episodes of LRTI with copious expectoration. That should also lead us to think whether there can be a component of bronchiectasis. So, and the past history, the important history here is she was having history of recurrent childhood pneumonias from since childhood. She was having recurrent respiratory tract infections. So that should make us think whether there is any component of immunodeficiency. So since the initial clinical picture and on auscultation, she was having post crepitations and the HRCT finding showed us bronchiectasis, we should look for what is the cause of bronchiectasis. So that made us send this immunodeficiency workup. So if there is history pointing towards some recurrent infection suggesting that there is some underlying immunodeficiency, then we can send for these tests.
Anybody else has any questions? We can proceed.
Thank you.
Good morning, everybody. So I'll go on to the laboratory tests that we do for the diagnosis of CGD. So as discussed, CGD is a rare inherited immunodeficiency syndrome with impaired function of phagocytes. They can have an X-linked or an autosomal recessive pattern of inheritance where there is a defect in the NADPH oxidase complex. So because if there is a defect in the NADPH oxidase, this results in a lack or reduced amounts of superoxide or reactive oxygen species formation. Now, this is a main oxygen species which is going to cause death of the microbicidal action. So this is very important. So if absence of this will lead to immunodeficiencies. So we do 2 tests in the lab for diagnosis of CGD, the NBT test, which is a laboratory screening test, which is not very sensitive. So we have usually a qualitative test. We say that's absence staining or normal staining. The other test, which is more sensitive and the method of choice for diagnosis of CGD is the dihydrorhodamine test by flow cytometry. So the NBT is the oldest laboratory test for CGD. It provides a simple and rapid, but largely qualitative determination of the NADPH oxidase activity. As she mentioned before, the neutrophils are going to convert the yellow soluble dye NBT to insoluble dark blue or black formazine pigment, which precipitates within the neutrophils. So we examine the slide under the microscope and look for these precipitate or pigments within the neutrophils. We need an EDTA sample. We take the buffet code to concentrate and get more WBCs, and we mix with the NBT reagent. We incubate for 30 minutes at 37 degrees Celsius, and then we make a smear and counter stain with a stain to identify the WBCs. So this is how a control, we always run the control simultaneously. This is how a control or normal one should look like. Now, depending upon the stain used, the kind of color of the pigment can be different. So in our stain, the background is pink. We can identify the neutrophils by the multilobulated pattern. And you expect to see such black, intense, dark precipitate as seen. So if we see this, we say it's a normal staining, which is a normal neutrophil oxidative function. Now, this is the case. Now, for this patient, we had only the NBT test, and this is a slide from our patient where there was no staining in the neutrophils. Now, you can see the neutrophils by the multilobulated kind of pattern, but there is no staining within the neutrophils. So this is suggestive of CGD. So this is another case of CGD. Again, you can see multiple neutrophils, but there is no staining. Again, I don't know whether you can see in this slide, there is faint staining in some of the cells, but this is not considered positive. We need to see intense staining, only then we'll call it normal. This kind is what we call the type 2 kind of staining, which can also be seen in CGD cases. So we need to look carefully at the neutrophils and look for this intense black staining like this case. Now coming to the next test, the dihydrorhodamine test. So dihydrorhodamine is a non-fluorescent rhodamine derivative. So this is taken up by the phagocytes, and when oxidized to rhodamine, it emits fluorescence. Now to activate the neutrophils or NADPH doesn't get activated by itself on a resting neutrophil. We add a substance called PMA or phobol mestate acetate. This is present, one of the cell contents of the bacterial cell wall. So when we add this to the tube, this activates the NADPH oxidase and there is production of reactive oxygen species. Now this reactive oxygen species is going to convert dihydrorhodamine to rhodamine. Now rhodamine is a fluorescent compound which emits fluorescence, which can be detected by flow cytometry. So again, for this, we need a heparin sample. We have two tubes. So the first tube, we add blood and dihydrorhodamine. And the second tube, we add whole blood, dihydrorhodamine, and PMA. So first, the heparinized blood is diluted and mixed with DHR. And it is incubated for 15 minutes. So in this time, the DHR gets taken up by the neutrophil. So it gets loaded onto the neutrophils. Now, at the end of incubation period, we are adding the PMA solution, which is going to activate the NADPH oxidase within the neutrophils only to the second tube. Okay, so this results in the production of reactive oxygen species if the phagocytic function is working well, and it is going to convert dihydrorhodamine into rhodamine. Okay, rhodamine emits fluorescence, and this can be detected by flow cytometry. Now, we run a control every time to make sure that the reagents are working properly. So this is an example of a normal staining. So, so the pink population that you see here, which is gated, is a granulocyte. So that is a population of interest for us. And you can see that this is with DHR without activation by PME. So you see that there is no fluorescence which is emitted in this case in the first tube. And we also can calculate it objectively by the median fluorescent intensity of the neutrophils. The flow cytometer gives us a value. So in this case, it was 123.2 without PMA. Now, after adding PMA, again, the granulocytes are gated. You see that there's a distinct shift of fluorescence. Okay, because the dihydrorhodamine is converted to rhodamine and it is emitting fluorescence. And we can objectively calculate. So in this case, it is 40,000 something, and we calculate what is known as a neutrophil oxidative index, which is a ratio of the tube with the MFI with PMA by the tube without PMA, and in this case it is 327.4. A normal index is considered more than 100. So anything more than 100 suggests a normal neutrophil oxidative function. This is not our case because we did not have a DHR sample for this case, but this is a case which is diagnosed as CGD in the lab. So here you can see that this is the first tube without PMA activation, and this is after adding PMA. So even after adding PMA, there is no shift in the fluorescence, and the ratio is almost equal to 1. Okay, so this is classically what is seen in CGD. Now, I mentioned that the CGD can have an X-linked recessive pattern or an autosomal recessive pattern. In X-linked recessive, we see this ratio very close to 1. But in autosomal recessive, it is a little more broader curve. I don't have a picture of that case right now, but I can show you a picture from an article which compares the X-linked recessive and the autosomal recessive pattern. So here the peak is very narrow and the ratio is almost close to 1. While in autosomal recessive, the ratio will be in the range of 10 to 50. It will be reduced, but it will be a little more broader peak than what you see for an X-linked recessive. Another way to identify the X-linked recessive versus the autosomal recessive is to screen for the mother. When the mothers are carriers in the X-linked recessive cases, so in those cases, we see a bifid or a two peaks in the DHR, which I can show you. So this is one of our cases again. So this is a mother which was screened recently about a month back. And I think the child is still admitted here is what I understand. So here you see the DHR again, the tube, this is the MFI of the neutrophils. And here you see two peaks in the granulocytes. So there is one peak are not getting activated and another peak for the neutrophils are getting activated. And you can see when you calculate the NOI, it is 1.2 and 362%. So this is a pattern that we see for carriers of X-linked CGD. So if you want to differentiate an autosomal recessive versus an X-linked, you can screen for the mother. The mothers of autosomal recessive usually have a normal pattern. So this is the article. So just to show you how autosomal recessive pattern will look like, it will have a more broader pattern. Again, you can screen for the mother, which is easier way and a more objective way for identifying the bimodal pattern. So before points to consider before identification, we need fresh samples because neutrophils have short half-life. So we cannot use a sample which is more than 24 hours old. Ideally, it should be less than 12 hours old. We need heparin sample. And in cases, patients with myeloperoxidase deficiency can also show a false, can reduce DHR activity, giving a false positive result because MPO, but MPO deficiency patients are generally not symptomatic. Okay, but it can give a false positive DHR. But there are ways to identify this. Like we always run our samples in the ADVIA cell counter, the patients who have suspected to have CGD. Now the ADVIA cell counter use a peroxidase stain to differentiate the neutrophils. So here the x-axis is the peroxidase activity and the cells seen here in the purple are the neutrophils. So here, this is how a normal sample should look like. The neutrophils should have a high peroxidase activity. So if we have a positive, like an absent neutrophil DHR staining, then we DHR in the flow cytometry, then we look at the ADVIA staining to see whether the peroxidase activity is good. If the peroxidase activity is good, then it is not an MPO deficiency, then it's likely to be a true CGD. Okay, so we run this sample, CBC sample in the ADVIA cell counter for all cases. The other ways to identify the differentiate MPO, generally the NBT, though the DHR can give a false positive result, the NBT is usually positive. So when you have discrepancy between the NBT, where the NBT is showing normal staining and the DHR is showing a absent staining, then you need to think of an MPO deficiency. MPO deficiency is usually, again, clinically not very symptomatic. And also you can look at the eosinophils in the DHR activity. Then generally in MPO deficiency, the neutrophils will show some DHR. So that can help to differentiate MPO versus CGD. So we usually look at the ADVIA cell counter and we also have the NBT to compare. Now we should be very careful when we have neutropenia patients because sometimes when the neutrophil count is low, the granulocyte gating can include some eosinophils and monocytes, which can give a falsely reduced value. So we have to be very careful about that. And patients with active infection and sepsis, again, can have a falsely reduced levels of DHR, but it's usually not like the CGD level markedly reduced. It will be that borderline around 100. So when we have a borderline value, when we are not suspecting CGD, then it should ideally be repeated at a later date to confirm. Thank you.
Thank you, Dr. Tulsi. Just a quick doubt I have. So we do come across these recurrent respiratory infections, and one differential we would always like to roll out is CGD. So which will be the one test to send? Is it straight away DHR, or it should be like you do a
DHR is a more sensitive test,
okay,
and it is a more robust test. So if you have to choose one test for CGD, it has to be DHR. But if it is a cost constraint, you want to first look for NBT, and if the NBT is negative, then definitely it
Yeah.
should be evaluated.
Still, the
But
clinical
again,
suspicion is high. We have
yeah,
to still,
I think if the clinical suspicion is high, then I think you should send for both together.
ideally both.
Yes.
Okay.
Okay.
Thank you.
Okay.
Now I'll ask Dr. Sathish to take us towards the pediatric aspects and further. Over to Dr. Sathish.
So good morning, everyone. And thanks to Dr. Jonathan, Academic Officer, Medicine Department, and Ashwin, given me this platform. So we do come across chronic granulomatous disease patient. Currently, the bimodal peak you have seen, that patient is admitted with us. We'll just see like how the CGD started, some history, and some case presentations, some odd presentations. So here, this picture I always quote or put it in every other presentation because the symbol for the immunodeficiency is zebra. So the zebra, to find out the zebras in your OPD, sometimes it is very difficult. But if you closely look it up, if you take some time and look it up, the zebra, you can find out the zebra here. Okay. So the immunodeficiency foundation symbol is zebra. So the zebra lies are there in your OPD. So this is the classical teaching. Whenever you hear the hoof beats, you always think of horses. So this is like the classical teaching. But our symbol is a zebra. So I have to quote that whenever your hoof beats, think zebra, not horses. So this epidemiological triad is very classical, like we have learned it from medicine. So agent, environment, and the host. Most of the time, we are more interested in the agent and the environment. Host, sometimes we evaluate or think very less. So this is the classical arm. When you see the autoinflammation, the host is with develops the antigen independent inflammation. And if the same host develop the antigen dependent inflammation, they are more prone to develop the autoimmunity and the allergen. If they are specifically the host is develop some pathogen susceptibility, they are more prone to develop the immunodeficiency. So this is the Jeffrey Model Foundation gives the 10 warning signs for the how to pick up immunodeficiency in the OPD. This is applicable for children when children is getting 4 or new ear infections and the 2 or more serious sinus infections in a year. And there is 2 or more months of antibiotics with a little effect and pneumonias within 1 year. And the child is failure to gain weight or grow normally, the recurrent deep-seated skin or organ abscess, especially when you have a chronic granulomatous disease, this particular symptomatology or the warning sign is very useful both for the adults. If the patient gets the recurrent infection, the deep skin or organ abscesses, and very well, the patient needs evaluation for a primary immunodeficiency. So these are all the other various other signs for the warning signs. The persistent oral thrush in the mouth, fungal infections in skin, and the need of intravenous antibiotics to clear infections, and the deep-seated infections, including septicemia, and if there is any family history of primary immunodeficiency. So these 10 warning signs is very useful to pick up the patients in a primary immunodeficiency in your general OPD. So see, I am always like, I am not a very bright student. I always think like, is there is any mnemonic is there to pick up these patients? So whenever any patient comes, is it a just infection? Or to if it is very difficult to remember 10 warning signs, at least you remember this spur. So this is very easy. So this mnemonic is very useful. Whenever any patient is very severe enough to require hospitalization and requiring intravenous antibiotics, if any persistent infection is there that clears very slowly, or any unusual organisms, our microbiology department is very good to pick up these all unusual organisms. The unusual organisms caused by uncommon organisms, and it keeps coming recurrence. And if there is any family history runs in the family, and the similar family member is having a same susceptibility to infections, this mnemonic is very useful to think of primary immunodeficiency in it applicable for both the medicine and the pediatric OPD. So this 2022, our International Union of Immunological Society upgraded. There is almost, we have now 500 unique mutations or the variants are there related to the inborn error of immunity. The 2024 we have upgraded, it is 585 mutations are there now. So is it difficult to make a diagnosis of primary immunodeficiency or inborn error of immunity? So my third call always says the eyes see only what the mind knows. So still I stick with my third call, and they say that the eyes sees only what the mind knows. So we'll see. So the story of the chronic granulomatous disease started in 1957. This was the very first paper they published in American Medical AMA Journal of Disease of Children. They said a fatal granulomatous disease of childhood. So this particular paper enlightened there is five unique symptomatology. One is like a chronic suppurative lymphadenopathy, the dermatitis, conjunctivitis, hepatosplenomegaly, and the pulmonary disease. So you can make out there is a age group. It is like very, very less, 4 months, 6 months, and it is less than 5 years. And they succumb to the illness at a very early year of age. So in this paper, they quoted there is some very unique pattern of increased gamma globulins and the leukocytosis there in this age group, in this particular cohort of people. So this is the pictures. They took so much of pain to take these pictures in a black and white photograph. And the class 3, you see there is a blepharitis and the dermatitis involving the columella, and there is a characteristic dermatitis and the cervical adenitis in the children. And there is a superficial ulceration with the raise in the base of the granulation tissue. So these are all the initial photographs is there for the chronic granulomatous disease in 1957. So after this is the autopsy photograph of a case 4 showing a multiple nodules present over the surface of the liver. When they sectioned it, they showed that unique granuloma was there. So far, the granulomas is there. Whenever any granulomas is there, we are more interested in tuberculosis and the sarcoid. We never thought of the chronic granulomatous disease. But there was a unique granuloma was there in this particular histopathological picture. This is suggestive of chronic granulomatous disease. And the summary of this particular paper says this is an unreported syndrome of chronic suppurative lymphadenitis and the hepatosplenomegaly, and there is a pulmonary infiltrations with the eczematoid dermatitis of characteristic description was described. And there is a granulomatous process associated with prominent hyper gamma globulinemia. So Dr. Tarun was asking, like, when you suspect a patient with a chronic granulomatous disease in the children group, whenever any neutrophilic leukocytosis with a hyper gamma is there, and there is recurrent infection, if lipid is a lymphadenitis, recurrent pneumonia, these are all the points we take it as significant and evaluate for the chronic granulomatous disease. And the new syndrome is differentiated from the other forms of infection and non-infectious granulomatous process in the childhood. And the last paragraph is, they said extensive empirical efforts at treatment of the disease have been without effect upon the relentless progression that would seem to be more characteristic features of this syndrome. This we are facing now also. This they described in 1957. So the types of CGD already Dr. Jamima mentioned. There is a X-linked CGD and there is a autosomal recessive CGD. There is a this is the GP21 CYBA and the CYBB. These are all the X-linked, and there is an autosomal recessive form of the chronic granulomatous disease is P4767, and there is a P40. So NADPH oxidase GP91 is like CYBB, it is a X-linked. So as Dr. Tulsi said, the X-linked CGD, they present very, very early manifestation. Now at present, the ward, when the baby was admitted with this child, admitted in the newborn period with the sepsis, in the blood culture, we have a candida, and the child is admitted again with the fever, and we are treating the child with the IV amphotericin B, assuming the child is having aspergillus. So this was the this is like published in the Frontiers in Immunology when I was working as a SR in PJAMR. And we have compiled the cases like the pan-India cohort of the 236 patients already mentioned. The autosomal recessive form is very unique, and we have seen a lot of autosomal recessive pattern in this pan-India cohort. So in the pan-India cohort, what we have observed, the median age of infections, and it is more common and earlier in the X-linked CGD compared to the autosomal recessive CGD. And you can make out the forms of infections what we can have in the chronic granulomatous disease. They can have superficial abscesses, deep abscesses, recurrent lymphadenitis, osteomyelitis, and the liver abscess. So the liver abscess story, I should tell you. So especially when you have a liver abscess related to the CGD, the treatment of choice is antibiotics plus steroid. So it is very, very contradictory statement. And when you go and tell the infection, if you want to give steroids, everybody will have a second thought, oh, what are you talking? But the drug of choice to treat liver abscess in the chronic granulomatous disease, steroid is the drug of choice. And there are non-infectious complications, and the manifestations also is there. So these are all the various signature organisms isolated in this particular cohort. If you see the Staphylococcus aureus, mycobacterial disease, especially in our cohort, like there are a lot of disseminated BCGosis. We have a BCG adenitis, and there is a tuberculosis also we have reported in our cohort. So these are all the various signature organisms. So whenever any patient gets admitted with the signature organisms, if it is a Burkholderia, I will have a second thought and go and evaluate this child for a chronic granulomatous disease. Especially when you have a Serratia and the Staphylococcus aureus is there in the the liver abscess, especially all these are all the points. Sometimes from the lab, you track the patients. So these are all the signature organisms for the chronic granulomatous disease. And especially when you have a fungi, the Aspergillus candida and the Candida tropicalis, especially the current index child with the X-linked CGD is having a candida in the blood culture. So this is not a contaminant. Sometimes we assume it is contaminant. This is not a contaminant. At the same time, if the candida is there, look after your total counts and the neutrophil counts. Ordering one NBT is not going to harm the patient. So you can break the diagnostic odyssey. So this in our cohort, like I just want to highlight these three pictures. These three pictures are having the children is having osteomyelitis in the fourth and the fifth finger, and the osteomyelitis in the ulna, and the osteomyelitis in the rib. So you can make out there is osteomyelitis in unusual places. Why the children should get a small bone osteomyelitis? Small bone osteomyelitis is not a routine area to get osteomyelitis. Unless if it is a sickle cell, you can agree that they can get osteomyelitis in the small bones. But the small bones in the osteomyelitis in the small bones and the ribs. So the rib is not like a routine area to develop osteomyelitis, especially in a CGD, the entity called mulch pneumonitis. We used to call they erode the ribs, and sometimes we excise the rib to get the culture. So this extent we used to go to identify the organisms. So this particular paper I want to quote because there is inflammatory complications with the CGDs. One of the complication is like HLH. So this particular first patient, when I was a SR in the first 6 months of PJMR, this child came to the ward with the illness at 40 days of life. When the 40 days of life, the child presented with abdomen distension, fever, pneumonia, abdomen distension with the hepatosplenomegaly. Ultrasound picked up splenic abscess. So splenic abscess, what is the thought usually we have? We'll have a bacteremia thought. But when the child, we further evaluated, we picked up the child was having a complication of HLH along with CGD. So you can assume when you pick up a patient with CGD, it is okay. When they come with a complication as a first presentation, it is very, very difficult. And this third patient, when I was managing, the child was from the East India. The child is known case of CGD while on prophylaxis. The child went to some West Bengal, there went to beach. The child had a bath in the swimming pool. We isolated a Francisella novatensis. This is a fish pathogen. This fish pathogen was a trigger for HLS for this particular child. The child was successfully transplanted and he is alive. So the drug of choice for the HLH in CGD is IVIG and the methylprednisolone. Again, it is like a contradictory statement. When you have an infection along with the complication, the drug of choice is like methylprednisolone here. At present, like from 2022 for 2025, we have 2 patients with a chronic granulomatous disease who developed HLH. We managed only with the pulse methylprednisolone and the oral steroids. So this is another inflammatory complication, the inflammatory bowel disease. We had encountered a patient with the inflammatory bowel disease. When the patient presented with this, like we have done a DHR, this was the normal DH, this is the control. This is the patient, you see like it is closely lie within the control. This is the mother's DHR, it was showing a bimodal peak. This is the X-linked CGD child as a presentation manifestation as an inflammatory bowel disease. So we have documented the granulomas in the colonic mucus biopsy. So Dr. Tulsi mentioned there is a CGD carriers. Those CGD carriers, these patients are there in the medicine OPD because they have the cutaneous manifestation as a photosensitive malar rash, discoid lupus, and recurrent aphthous stomatitis. There are various other forms of non-infectious manifestation in the CGD carriers. And you can see there is a lupus-like syndrome. Recently, there is a paper published. The woman had a lupus-like syndrome when she was getting recurrent infection. When they evaluated for the CGD, she was positive for CGD. So this is our cohort from 2010 to 2022. Dr. Anila and Melvin like compiled this data. We have started picking up the patients from almost 2012. Now there are a lot of patients with there, like 2020 to 2025, almost like we have almost 20 to 30 patients are there. So this is the various manifestations and the clinical features we had in our cohort. Predominantly is a pneumonia, the failure to thrive, the lymphadenitis. And you can see there is a HLH as a presentation and osteomyelitis. And one patient they presented with a typhoid. Blood culture was like, especially non-typhoidal salmonella, if it is there, please take a thought and evaluate for the immunodeficiency. If it is a non-typhoidal salmonella, sepsis or septicemia, if anything is there, that points favors towards evaluation for inborn error of immunity. So this is another patient, the adult ID gave me opportunity to evaluate. This is one 43-year-old index patient this year. And she had a fever on and off for 6 months and cough with mucopurulent expectoration for 6 months, bilateral chest pain and the worsening breathlessness for 6 months. So in the past, symptomatic since 15 years of age, she had she was diagnosed bronchiectasis, and she underwent right lobectomy at 20 years of the age, evaluated elsewhere, and she had a recurrent ear discharge, underwent a operation for CSOM at 30 years of the age. And because of recurrent sinusitis, she went for a FIS at 35 years of the age, and she was diagnosed at 39 years of age at inborn error of immunity. So this is the 43-year-old lady, and the brother died at a very early age, at 23 years of bronchiectasis, because he had a recurrent respiratory tract infection since 10 years of the age, empirically treated with antibiotics and tuberculosis medications. So we did an investigation. The immunoglobulin is 11.3 and the differentials are fairly okay. Platelets are normal. But if you see the immunoglobulin, there is a pan-hypogammaglobulinemia was there. And the flow cytometry we did to characterize the B cells, there is a decrease, absolutely decreased B cells, and followed by, when we sent a targeted panel for inborn error of immunity, the index patient had a RAG1. This is one of the form of a severe combined immunodeficiency, and her parents, both parents are carriers for the heterozygous state. And the child, I evaluated the lymphocyte subsets and the immunoglobulins, and the son is okay. And currently the index patient at the 43-year-old, she is monthly IVIG, and with oral antibiotic prophylaxis, her life is fairly good. So this is a son-father story. When the patient was admitted with us and evaluated for the fever for 75 days, we have diagnosed enteric fever, followed by he was admitted once with us. When we took a family history, there was a unique neurological problem father was having. So in 2006, he had a oral ulcers, lower limb edema, red painful lesions with healed hyperpigmentations, and he had a hemisensory symptoms, and the right thalamic infarct was there. That point at the time, he was on native medications. In 2008, when he came to the CMC, he was having a lower limb ulcers, right medial rectus palsy. They thought of neurobeshettes, started on prednisolone and azuran, and the azathioprine was continued, and he was like getting relapses with the skin ulcers, and they restarted the steroids and continued azathioprine, and he developed a transient ophthalmoplegia in 2018, and the blurring of the vision and the left side painless vision of painless loss of vision. Again, the steroid and MMF was started. And 2024 in our OPD, we have sent a genetics. We have picked up the deficiency of adenosine deaminase 2 homozygous pathogenic. So the father is having a DADA2, was having a lot of manifestation, like with the various neurological manifestations of a DADA2. So the DADA2, when you have, like when your residual activity is very low, you present very early with the pure red cell aplasia and the bone marrow failure syndrome. If your activity is fairly okay, you can end up in getting the vasculitis. So this is the story already, this particular platform we have presented. This is a 56-year-old male evaluated in our institute for 34 years and developed, he was having a non-smoker, evaluated for multiple times. The differentials considered tuberculosis, pancreatitis, and the peptic ulcer disease. N number of times we have done ultrasound, barium meal, and treated for the peptic ulcer disease. And he developed, 7 years later, he developed a pain in the right hand and the sudden onset discoloration of the right ring finger. So homocystinuria, cervical roof, vasculitis, and evaluated for these differentials. And the Doppler was showing a right upper limb Doppler was showing thrombotic occlusion in the proximal ulnar artery with the poor distal reformation of the collaterals. And that point at the time, vasculitis per se, when we said the C4 was low, other investigations are fairly okay. So this is the Doppler. There is a dampening in the right ulnar middle one, that there is a peak systolic velocity was dampened, and the distal part, it was okay. This is the right radial. And you were started on oral prednisolone, tapered over 3 months, and aspirin and warfarin was given. He lost follow-up, and followed by he was keep complaining the abdominal discomfort and some joint pain. Diagnosed inflammatory polyarthritis, methotrexate, SACS. Again, we evaluated the C4 was low. He was getting the intermittent pain and the swelling in the joints. 2 years later, he developed hemiplegia. He developed acute infarcts in the right occipital lobe and the right medial temporal and the right thalamus. And this is the family history. And this is the index patient. And this is her daughter, this is the granddaughter. All the three is having hereditary angioedema. And this is the extended family when we evaluated, and one of the relative was also having hereditary angioedema. So this is the child we evaluated. She's fairly okay now, and she's on tranexamic acid, and the granddaughter is also tranexamic acid. The C4 is low. We have done a NGS from our lab, was showing the serpingine mutation. So this is the extended family. This is the 3 patients I was mentioned in the photograph, and this is the whole extended family. These are all family members having hereditary angioedema. All these family members are in follow-up in the clinical immunology and the rheumatology OPD. So in hereditary angioedema, you see there are 44% they can have the misdiagnosis. These are all the various misdiagnoses they can have, especially gastroenteritis, constipation, diverticulitis, and psychological aspect. The daughter of that particular gentleman, we have sent the child to the CAP because she kept complaining abdominal pain. We have sent her to the CAP, but it is not a CAP problem. This is a routine hereditary angioedema problem. So inborn error of immunity, not only infection, more than the infection, what we have, there is autoimmune cytopenias, a lot of lymphoproliferation, and the cancer predisposition, endocrinopathy, enteropathy, and the systemic autoimmunity and the vasculitis. So immunodeficiency is one arm, that immune dysregulation disorders are there in the other arm. So this particular cohort of people is there in your OPD, the medicine OPD. So what one success story we can share? We have a patient at 2 months of old, he presented with only the perianal pustules. This child we diagnosed with the next generation sequencing interleukin 10 RA receptor mutation. We have transplanted. This is the condition of very early onset IBD. We have transplanted the child. The first transplant rejected, and the second transplant was success, and the child is doing well. So you can give rebirth to the child with the transplant. So the takeaway message is the inborn error of immunity will stop your, it can give some solution to your end of diagnostic ADC, and there is a prognosis management and the treatment. So it is not rare, and it is not only specific to the children. So the zebra is there in your OPD. So kindly pick up the zebras, and we are there to help anytime. And I thank the institution and my family, pediatric family, all the labs and the departments to support me to up to this level. Thanks.
Thank you, Dr. Sathish, for taking us through the pediatric aspects of immunodeficiency and inborn errors of metabolism. Any questions to Dr. Sathish?
So actually, Dr. Sathish, thanks a lot. I want to really appreciate your slides and covering so many aspects. It's a real testament to the registrars as well, how to prepare and present. And I think we've often heard this term, and I think this clinical meeting is often a zebra farm. We keep coming up with all these rare cases. And I think we have to balance deciding when to send tests. I hope Tulsi now doesn't get more NBTs flooding and more consults there. But we've also realized that a few clinical meetings ago, we had another 50-year-old person who had an inborn error of metabolism. So your advice to general medicine people who are going to see adolescents, young adults with this symptomatology. So you mentioned about the infections, but what would be the threshold? What would be the clues? And right now we have only one test. So the other thing is we've realized as NBT, we've picked up that we have to send an immunoglobulin. So the clinical suspicion and what should be the most reasonable set of tests that we send before we involve you?
Yeah, so thanks, Dr. Tarun. So usually the classical teaching, whenever you suspect inborn error of immunity, the first level of access is test is like complete blood count. So when you are hemoglobin, total count, and the differential counts, we always tune to see the neutrophils. Most of the time, we don't give recognition to the lymphocytes, especially when you have a severe immunodeficiency, the lymphopenia will be there. So we used to tell our registrars to calculate the absolute neutrophil count, absolute lymphocyte count, and absolute eosinophil counts. So the three things, like if anything is like, if it is eosinophil count, AEC is very high. The first, common is always common. And another thing, whenever you are thinking inborn error of immunity, primary immunodeficiency, kindly rule out HIV. So that is the dictum. If HIV is negative with the recurrent infections, there is a platform you can check all these investigations. Next is immunoglobulins. Another one is for innate immunity for phagocytic defect, the NBT and the DHR. The next level of the tier of investigation is flow cytometry. The flow cytometry, our flow cytometry gives T, B, NK cells, and the switch memory cells, and the naive CD4, CD8 cells. So these are all the first level of access you can check. So this fairly like accessible in all the things. And the next is the genetics, and depends upon the condition what genetics we are going to send. There are sometimes we go for Sanger, sometimes we go for a targeted panel in our lab. If it is like very complex autoinflammatory syndrome, we used to send the whole exome outside. So these are all the panel of tests we have for the primary immunodeficiency suspicion. And if any, the other thing that spur, you can take it as very significant and a severe infection, persistent and unusual organisms with the recurrence and family history. Most of the time, the pedigree, most of the time that we don't give so much importance to the pedigree. The pedigree gives fair amount of idea, like whether it runs in the families. If it is runs in the family, straightforwardly they have to evaluate. So yesterday I have seen a patient. The brother was having a recurrent fungal infection in the nail. So sister is having ITP, and the father is also having the same problem. So unless if you don't take this family history and we don't think about inborn error of immunity. So the one thing like MSMD, there is a entity called Mendelian susceptibility to mycobacterial disease. Once I called in a dermatology ward to see one patient with vasculitis. So the outside diagnosed HSP vasculitis, but when you plotted the pedigree, the aunt was having tuberculosis, the grandfather was having tuberculosis, everybody was having tuberculosis. So this warranted straight away to evaluate for this inborn error of immunity. And there is some group, like we usually divide combined immunodeficiency, severe combined immunodeficiency, disorders of phagocyte, disorders of complements, disorders of inflammasomes, and there is a disorders of hyperinflammation, especially CG, HLH, and other stuffs. There are some forms of familial HLHs also we have. So when you have hypopigmentary disorders, Griscelli syndrome, Chidiac Higashi, that is straight away warrants the hair microscope examination and confirms the diagnosis.
Thank you, Dr. Sathish. Any other queries from the floor? Thank you for the opportunity. And then
I had a question to the perhaps the ADMET team. So a lot of times we pick up bronchiectasis incidentally on imaging, or the patient is admitted with another systemic illness and had a cross-sectional. At what point do we decide that, okay, I need to work up for the etiology of the bronchiectasis, especially if it's a unilateral or focal? At what time do we decide that we should work up for etiology?
Sure. So usually it starts with, particularly in a tropical country and an endemic country like India, we always start with ruling out for TB. And then, like Dr. Sathish said, we always go back to the childhood history. Any childhood history of probable TB or recurrent pneumonias or even measles can predispose to bronchiectasis. So that history we will take. And then we will look for other multi-system involvement and also family history of similar illnesses. So ruling out this will be, so whatever we have projected, we did the first initial battery of tests, ruled out the common things, then go for the uncommon things. Here, historically, she had recurrent infections, no history of TB, no measles. But despite a complete vaccination, and she kept having recurrent infections, and she manifested in her late 20s and early 30s with bronchiectatic features. So the next thing, particularly in her female patient, we always, next step is to rule out a connective tissue disease. So the common panel we send is ANA and RF. If ANA turns positive, then we do an extended CTD workup. And if that turns negative, then we look at immune. So two ways we look. The initial panel negative, we move to immunodeficiency things, or recurrent multi-system, we look at immune deficiency states. So then we send the combined CVID workup with the form of complete immunoglobulin panel. And we also send the CGD workup. The next level, what we do usually is to send for flow cytometry. Flow cytometry is expensive, so that's why we usually restrict and we go in a stepwise fashion. Thank you.
I just want to also highlight, we have 4 departments here: pediatrics, clinical pathology, as well as respiratory medicine. And this is all for the learning of postgraduates, consultants, so that we can take care of our patients better. So thanks for organizing this to M5. Thank you all for coming, and hope we can have more of this. Please feel free to call medicine if you all need anything from our side. Looking forward to the next clinical meeting. Thank you.
Thanks.
Thank you. Very good.